Today, we will have a fantastic panel for discussing the rise of transradial access around the world, to discuss the evolution of this technique and to discuss the future direction of transradial approach. We will start by a great discussion with the pioneers of this technique. We have the chance today to have with us Professor James Nolan from UK, Dr. Olivier Bertrand from Quebec, Canada, Dr. Jan Gilskreet from US, and Shigeru Saito from Japan. To start the discussion, my first question will go to Dr. Shigeru Saito from Japan. Shigeru, I know that you start very early, at really the beginning of this technique 30 years ago. How did you first radial artery procedure go, and how would the patient react in your center?
Thank you very much for your question. Actually, I started the Transradial approach 27 years ago, October 1995. I visited Dr. Wu in Taiwan to demonstrate how to do stent implantation. However, during my procedure intermissions, I saw several cases were done by Taiwanese doctors. And I was so much surprised to see some of the procedures were conducted from radial. That was my first time to see this kind of technique. And also, I also surprised to realize that very small body patients, like Japanese, they can accept the radial access. That was so surprised to me. And then I have decided to completely convert my technique to transradial. And the next day, after coming back to Japan, I declared my young colleague that I would change my practice completely, totally to transradial. And then actually, that was October 12, 95. That was my first case. Not only my case, but also the first case in Japan to do transradial access. The patient age was 84, and she was very sick. And she had compression fracture of the spine. So the bone are, tortuous. The artery tortuous, and then the access from the groin seemed very difficult because of the heavy tortuosity. So I told the patients that I will treat you by wrist access. The patient was so surprised. What? She couldn't understand. But the procedure was done by myself, actually. And then in 35 minutes, I started the puncture and catheter insertion and angiography, and found several lesions, and I placed the palmar stent there, and then finished. And after finishment, the patient could walk. So surprising. This was the first experience for me in my hospital and also in Japan. Thank you.
Thank you, Shigeru. So really talking about your first experience, your first Japan in your center, your first patient in your center, and first patient in Japan. I have a question now to Jan Gilskreet and James Nolan about the challenges. What were your biggest challenges when you started so many years ago?
The challenge that I was trying to meet was sort of similar to what Dr. Saito ran into, and that was I had my wife, Judy Hupsey, had federal grants and was interviewing critically ill patients and their families about their experience. And the two things that they didn't like about their experience were chest tubes being pulled and femoral catheterizations. And although they remembered very little about their hospitalizations, that gave a burning reminder of their experience. And at the same time, my colleague, Mark Kozak, had gone up to see Gerard Barbeau up in Quebec City and had seen radial. And it sort of, watching him do a couple radials, it sort of clicked in my mind that this might be a nice way to open up the patient experience. And so this was back in 95 also, the latter part of the year. And it wasn't very long before the patients were celebrating that they could walk around freely in our recovery area with their wristbands on, and thought this was the most wonderful procedure they'd ever experienced. And that was really the challenge that I was trying to match, was how could I make the patient experience better? And it was really the patients that sold me on moving forward with radial. I had no idea it might have a mortality difference or anything else. It was the fact that the patients were so happy to be done, pulling up their wrists to show me, and they called that the gill wrist sign of a good procedure, that the local patients were showing off their wrists in the grocery stores.
As you know, Jean, in 95, I went over and I was at one of the first OLVG courses, and then I was able to go back in 96. And when I came back, there was virtually no radial activity in the UK. And as I look back now, when almost every case is done via radial access, it's hard for today's cardiologists to understand that in 95, 96, 97, there was tremendous resistance to the implementation of radial access. We didn't have a lot of data. We could see that it was better. It was better for the patients. They could mobilize quickly, all of these things, but we didn't have a lot of trial data to support what we were doing. And I think in common with many big step changes in cardiology practice, radial access was a challenge to the orthodox way of doing things. So at that time, angioplasty cases were done from femoral access with a big static 8 French guide. And to move to radial access with 6 French guides, with a different way of puncturing, with managing challenges of dynamic catheter support, it was a very big challenge to the orthodox way of doing things. And I think many cardiologists at the time had practiced for many years with that standard femoral access approach, and they found it hard to accept the changes. And so, convincing colleagues and overcoming cultural resistance to that change was probably the biggest challenge.
Thank you, James. And I have a question now to Dr. Olivier Bertrand and also for Shigeru Saito about the evolution of the material. How the evolution of materials changed your practice?
We moved from a world where there was a static positioning from the operator using big size guiding. I think the norm from anything complex was 7 and 8 French at the time. And we moved away, and if you remember, we did a survey in 2010, and we asked the radialists around the world, do you need really to learn new catheter shapes to do a radial approach? And we were surprised to say that you can. I mean, if you remember that the first generation pioneers like yourself, Dr. Barbeau, Dr. Kimone had designed their own shapes, but it was something like a mindset for operators, so they could move and use any type of diagnostic or guiding catheter they were using for the femoral, because, it had moved now from the 7 and 8 French to 6 and later to even 5 French. So everything went down. And so if I summarize the second step, I think in technological advance, I may think of is the more recent advance in radial in sheet. As you know, we used to know that a sheet was basically 2 French larger than the guiding. So that could create a problem with a tiny wrist and a tiny artery. So the recent evolution of thin-walled slender sheet, I think, are probably the two main technical factors that help optimize result with radial approach.
Thank you, Olivier. And what about you, Shigeru, about the evolution of the material in transradial access and the changes in the way to perform the procedures?
For me, the evolution is very important to expand the indication of transradial approach. We cannot forget the advancement or evolution of the guide wires or stent system or arterial ablation system like orbital atherectomy. Before introducing these materials, we could not treat the patient with very complex region. So every evolution expanded the indication of transradial approach. So I'm always thanks to this kind of evolution. Thank you.
Thank you, Shigeru. And I think we can move now on the result of the different trials and of course the different consensus paper. And today we have a strong guideline in the US and in Europe. So my question first to Jan about the impact of these major trials and guidelines in your practice.
As I mentioned earlier, my interest was in the patient's experience, but I wanted to share that with other people. And as Jim Nolan mentioned, when you started to talk about this new disruptive technology, cardiologists just wanted to do what they'd been doing, only a little better, but they didn't want to try something new to make things better. They wanted to make better what they used to do. And in my sort of crusade to try to get people to switch, these major trials, I think, formed the foundation for pushing back on the old guard wanting to keep things the same. It's hard to explain to them that your patient will be better or feel better, but it's a lot easier to point out that your patient's more likely to be alive if it's done radially than femoral. And those types of data coming out of these trials, I think, formed the ammunition that those of us that wanted to advocate for radial needed. It wasn't just our soft feelings that this was a better procedure, but we actually could explain to our audiences, explain to our fellow doubters that there was something really here. And that's the value I found in the major trials. And certainly consensus papers and guidelines are helpful, but at least as you probably recognize, the US guidelines often lag significantly behind other world guidelines, and they're more of a lagging indicator rather than a leading indicator of where to go, at least in the US. I don't know, I'll pass it over to Jim to see what else he has to say.
I think for the first 10 or 15 years of practice in radial access, the data that we were able to collect was almost exclusively observational. And while it was positive and encouraging and useful, we were often challenged that we didn't have any randomized controlled trial data. And of course, the rival trial in 2011 and the subsequent series of randomized trials, ending up with the Matrix trial and in between several others, provided irrefutable data from large-scale randomized trials that radial access would improve patient outcomes in terms of reducing vascular complications, reducing bleeding, and in some subsets, reducing mortality. And I think that those randomized trials over that kind of 10, 12-year period were incredibly powerful tools. They inform the production of international guidelines, which are, again, useful things. So I think the trial data for the use of radial access is now very positive. And as well as these randomized trials in their selected populations, we've been able to use the UK database in hundreds and hundreds of thousands of cases comparing radial and femoral access, and shown that the randomized trial outcomes can be achieved in routine day-to-day practice. So I think, the story of radial access has been informed by very well-constructed trials, and I think that has given us a very strong background to advocate for the use of radial access in almost all of our patients.
I think the other thing that all these trials showed, even from the very beginning, was that although we were heading down a different pathway, we weren't harming any patients. And, I had femoralists tell me that they were picking up wrists and hands in the parking lot after my procedures. And that was never shown from the very beginning. So from my viewpoint of the patient experience, there was no harm here, and there was building benefit in the data. And I think that was a real powerful message.
Yeah, one other comment here would be that in the early days, we were often challenged that radial access caused more strokes, that complex procedures couldn't be done by radial access. There were multiple challenges put in the way. There was more radiation, the procedures took longer, etc., etc. And sequentially, all of those assertions have been disproved by the collection of trial and publication of trial data.
That's true.
Well, thank you, Jan and James, and for this perspective and the impact of the trial, the guideline in your practice, in your center. I have now a question for could be Olivier, and concerning the financial aspect. Did you see in your practice, did you see in your center positive aspect, a cost benefit of transradial approach compared to the transfemoral access?
Well, thank you, Jean. I think it's, of course, very important, and what is probably even more important than some years ago. If we want to make the equation quite simple, I think there are two ways of analyzing the evolution and the results of the radial approach compared to the femoral approach. Is that if you reduce complications, whatever the complication can be, and I think that as Jim summarized it, it's quite clear that we reduce all kinds of complications to different degrees. If you reduce complications to medicine, you reduce cost. I think that whatever the health systems, that's point number one. I think that we also spend, depending of the health environment, when you reduce complications and you speed up recovery, like Ian mentioned it, it was obvious that from the patient perspective, they could stand up right after the procedures or standing in a chair instead of lying in a bed for hours. Well, then you think that you can basically discharge patient much earlier. And I think radial approach was at the forefront to demonstrate that we could move to same-day discharge PCI. So my take on is that we reduce complications to substantial degrees, and as a result of speed up recovery, you can create same-day discharge PCI, and of course, whatever the system, everybody benefits.
Thank you, Olivier. James, do you agree with the comment of Olivier? And what about for you in your center, the financial impact and the cost benefit of transradial access?
Yeah, I agree with all of Olivier's comments. And when I think back now, it seems incredible to say this, but the standard practice when I began to do angioplasty was to admit patients to the coronary care unit overnight, often on a heparin infusion with the sheath in situ, take it out the next day, mobilize them that day and send them home the day after. When I came to the center where I now work, I actually had to go onto the ward and take the ECG leads off the patients and get them out of bed myself on that day and say to the staff, you do not need to do this. And this person can go home at 6 p.m. it was an incredible cultural battle that occurred around it for some time. When you look on a larger scale, the savings in health expenditures through the prevention of complications, rapid mobilization, reduced nursing care levels are very significant. And our own cost analysis from the BSIS databases that radial access compared to femoral access saves about 20% of total healthcare costs. And in the UK, over the next 10 years, that is heading towards £100 million cost saving for our healthcare system. So, it's an important thing. It's not just about improving quality of life. It does improve expenditure and efficiency in a healthcare service.
Thank you very much, James. And this symposium, we will talk during this symposium about the evolution of this technique, the future direction of transradial access. So I have the same question for all of you. And what about for you the future of radial access? So first, Olivier.
I think the fight is over to convince people about coronary intervention. We should focus on education and basically teach people how to do it. That's for sure. So it will continue, something that we have been doing for all of us for more than 25 years. I think the future will be in peripheral, especially like for stroke intervention. As you know, neurointervention are discovering the intervention percutaneous in an environment when there is high bleeding risk. So that's perfect for radial approach. And my second comment will be that we all know that we have been doing radial for quality of life for patients. It's obvious. I think that Ian explained it. We are in a new era. The world is changing. And I think that radial also can be associated with improvement in quality of life of physician. And I would just give an example. Instead of waiting 5 p.m. the call because the patient has pain and then you suspect a retroperitoneal bleeding, then you stay in the hospital because you need a CT scan. This is over. The patient are leaving and you are leaving early. So for the new generation that don't want to spend lives in the hospital when we used to do, I think it's also very important for the future of radial.
Thank you. Very clear, Olivier. And so same question to Jan about how do you see the future of the radial access?
Well, I'll take a slightly different tact on this, and that is radial, I think, has taught us the importance of good vascular access. So to do a radial artery cath, you have to be fairly precise in your needle stick. And we've learned that there's more to this world than just femoral arteries. And it's allowed us to, one, improve our techniques for all our arteries. We can take the lessons from our radial experience and use it on the femoral. Now we have axillary access. Some people are using carotid access. And just locally in the radial environment, we have the dorsal radial, which is another area. And all these can build on, good access techniques that have come about from our radial experience. The radial experience showed the femoral experience was a bloody mess, so to speak. And that has prompted a reevaluation of how we get access that's probably really uplifted the femoral group. So I think radial is part of a leading edge of how to access the body most appropriately for the tools you have. So, certainly peripheral work is something that's lagged behind the coronary work from the radial and is an area for growth. There's also the cerebral vascular area that's also open for growth. But I think the lessons of radial are really the lessons of how to optimize vascular access, and we can build on that going towards the future.
Thank you, Jan. What about you, Shiguru?
Even if the patient needs radial access, if the patient has no radial access, radial pulsation, in that case, we cannot do transradial approach. So that means we have to preserve the radial artery pulsation forever. So we have to focus on how we can prevent the radial arterial occlusion, RAO. This is the most serious questions, serious issues. So maybe next 10 years, we have to discuss, we have to investigate, we have to focus on these issues. That is my perspectives. Thank you.
Thank you, Shiguro. And finally, James, how do you see the future of radial access?
Well, I think it depends on the radial activity rate in your country. And if you're in a country where there is still a large amount of femoral access, I think the future is tied up with supporting that transition from predominantly femoral to predominantly radial access. In a country like the UK, where almost every coronary procedure is done with radial access, I think what I see now is a big growth in non-coronary radial access. So for things like peripheral interventions, neuroradiology, the interventional radiologists in our country are now interested in and practicing radial access. They have different challenges in their patient populations and the way the procedures have to be done. But we can help them, we can support them. We have made mistakes along the way. We can help them to avoid some of those things. So I think the future is the expansion of radial access out with the coronary sphere in countries where radial access is dominant. I guess the last thing I would say is I would echo Ian's comments there that being a good radial operator is part of a portfolio of advanced arterial access techniques, and it needs to be married with the ability to do distal radial procedures in some or many patients, and also to perform optimal transfemoral access using ultrasound guidance so that you minimize your risks when you have to do a femoral procedure or when you're in the structural lab. And I think that's going to be important in the future.
Thank you, James. And I would like really to thank you, all of you, James, Olivier, Jan, and Shiguro, for this very nice discussion on the rise of transradial access around the world